Hi everyone, my name is Manur and I'm a final year medical graduate from Liaquat National Hospital and Medical College, Karachi. I had a lot of exposure with multiple myeloma on my elective at Cleveland Clinic with Dr. Faiz Anwar and Dr. Shehzad Raza, and I'm going to be presenting on this topic. I have divided this into two parts, part one being the introduction, clinical and pathological features and imaging, and part two being more towards diagnostics and treatments. So I apologize if this lecture cuts off abruptly, but I promise we're going to continue right off it in session number two and talk about diagnostic, treatment, algorithms, and all other interesting stuff. So, what is multiple myeloma? By definition, it is a neoplastic proliferation of plasma cells that produce a monoclonal immunoglobulin. This is a definition we have been reading in all our preclinical years, but it was really hard for me to understand until I saw Dr. Faiz make one of these diagrams or something similar for his patients in his OPD, and I found it really interesting and very easy to comprehend, and I hope you guys too. But here, basically, in orange is a bone marrow, and we know it makes your RBCs, your platelets, your WBCs, and then there are your plasma cells, which is a variant of it that goes on to make IgG, IgA, IgM, Ig, and IgD, all your immunoglobulins. And these immunoglobulins are made up of heavy chains and light chains, and then light chains are linked with your kappa and lambda. Like light chains have your kappa regions and your lambda regions. So multiple myeloma is basically this plasma cell disorder in which your plasma cells are proliferating and they're making these immunoglobulins, one of these, and the rest of them are being suppressed. And then these immunoglobulins obviously linked with these light chains, kappa, lambda. This general layout usually helps a lot in understanding the whole basis of the disease. This is a very uncommon cancer. It only comprises of 1 to 2% of all cancers. It is more common in males compared to females and has a predisposition for African American descent. It is a cancer of older age, approximately 65 to 74 years, which is the median age of diagnosis. But I have seen patients with age 40 to age 50 being diagnosed with multiple myeloma in Cleveland Clinic OPD itself. So on further literature review, I personally read that 10% of the cases fall out of this median category, but as a general rule of thumb, it is a cancer of older age. It presents with a spectrum. So what we read in our preclinical years were the CRAP symptoms, your basic calcium, renal, anemia, and bone. But there are multiple other findings that can happen with multiple myeloma. They are obviously rare, but they are present. But myeloma defining events are the general CRAB that you can remember with the acronym. A lot of the signs and symptoms are usually due to damage from excess light chains into the bone or kidney. You can have your calcium elevation, which is found in 28%, renal insufficiency found in 48% of the patients. You can have anemia, which is found in 73% of the patients, the most common finding. And then you can have bone disease, which is found in 58% of the patients. Another common finding. Less common symptoms are paresthesia, hepatomegaly, splenomegaly, lymphadenopathy, and fever. What about increased serum protein levels? So we usually hear that people with multiple myeloma have increased serum protein levels, and it is found usually with other signs and symptoms of multiple myeloma. However, it is not necessary that everyone with multiple myeloma will have an increased serum protein. For example, somebody with a multiple myeloma with light chain predominance will likely have like a normal serum protein because the increase in light chains is not sufficient enough to cause rise in total protein levels. So does everyone with multiple myeloma have a serum protein level increased? No. Is it a finding which is commonly found in multiple myeloma? Yes. There's also this another diagnostic thing that we read about called extramedullary plasmacytoma, which is seen in approximately 7% of the patients with multiple myeloma at the time of diagnosis. We do diagnose it by CT scan or PET. Basically, if there is solitary proliferation of plasma cells, it is going to be solitary plasmacytoma. And if there is going to be multiple proliferation of plasma cells, it's going to be multiple myeloma. If the solitary or localized proliferation is in the bone marrow, it's going to be a solitary plasmacytoma of the bone. And if it's outside the bone marrow, it's going to be extramedullary plasmacytoma. So that's the general basic idea of it. 7% of the patient with multiple myeloma will have an EP at the time of diagnosis. And what the significance of this presentation is that these people usually have like an inferior survival, like their chances or rates of survival are typically lower compared to somebody who is not presenting with an EP at diagnosis. There's also a 6% chance that somebody will develop EP in the course of their myeloma disease. So that's what we have for extramedullary plasmacytoma. Here's an image of it, which I found on the internet. Anemia. Anemia is the most common finding for multiple myeloma. Approximately 73% of the patients have it at the time of diagnosis, and 97% of the patients will have multiple myeloma, will have anemia throughout their course of multiple myeloma at some point. This anemia usually results in a lot of fatigue and a lot of pallor that we see in that we see on physical examination in patients with multiple myeloma. Obviously, this anemia can reflect multiple things. It can reflect the bone marrow replacement by oncogenic plasma cells. It can reflect your erythropoietin insufficiency because of kidney damage, because of multiple myeloma. So the anemia is normocytic and normochromic. Some patients do present with macrocytosis and low vitamin B12 levels, but since we do not have like any direct link between vitamin B12 levels and multiple myeloma, we usually recommend these patients be worked up for other disorders like pernicious anemia, which can present with low vitamin B12. Bone pain. Multiple myeloma usually has osteolytic bone lesions, which causes osteolytic bone disease, which is a major feature of multiple myeloma, and this results in bone pain and pathological fractures. Multiple myeloma-related bone pain is usually involving the central skeleton, which is like your back, your neck, your shoulders, hip, pelvis. Does not involve the extremities. It can, but it's rare. It is less common at night and it's mild to moderate in intensity, but obviously the severity differentiates from person to person. This bone pain can also reflect a plasma cell tumor, such as a plasmacytoma, which can be an expanding tumor from the bone or a non-osseous soft tissue mass. So multiple different etiologies, but bone pain is generally present in people with multiple myeloma and is a major feature of the disease. Kidney disease. So kidney failure may be the presenting manifestation of multiple myeloma. A lot of patients present with increased creatinine. I think one half of the patients present with increased creatinine when they present with the diagnosis of multiple myeloma. Usually it is due to light chain cast nephropathy, and we usually refer this term as myeloma kidney. There are other causes of kidney failure in multiple myeloma, like light chain amyloidosis, drug-induced kidney damage, but kidney disease, rise creatinine, all of it does point toward multiple myeloma during diagnosis uh, in the clinic. So hypercalcemia. Multiple myeloma usually does have hypercalcemia because, like we read in the previous slide, there's like osteolytic bone lesions, and this is due to multiple myeloma-induced bone demineralization that causes hypercalcemia. It is found in 28% of the patients at the time of diagnosis. A tie-in to medicine that I found was that this can present with low anion gap because hypercalcemia acts as an unmeasured cation. There is a chart here that you can use for review. This is from UpToDate that is highlighting other causes of low serum anion gap and negative serum anion gap. I just found it interesting, so I included it, obviously. Neurological disease. So there is a neurological component related to multiple myeloma that can be due to extradural spinal cord compression. So you can have your spinal cord compression because of an extramedullary plasmacytoma, or there can be a bone fragment due to the fracture of your vertebral body, which can cause compression of the spinal cord. You can have hyperviscosity syndrome. Obviously, this is most commonly seen with IgM multiple myeloma. Because IgM is so large in size, it makes the blood very thick and viscous, and usually the patients present with blurred visions, confusion, neurological symptoms. You can have thoracic or lumbosacral radiculopathy, and this is also a very common neurological complication of multiple myeloma. You can have it by, again, compression because of a plasmacytoma, or like a collapsed bone itself that can cause like a vertebral body compression fracture. You can have peripheral neuropathy, but peripheral neuropathy in multiple myeloma does not occur on its own. Usually, when it's present, there is a concurrent amyloidosis happening. Um, Compared to POMS, which is a separate syndrome, peripheral neuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. In these patients, every single patient will have peripheral neuropathy, but when you compare this with multiple myeloma, usually if there's peripheral neuropathy present, the patient is also going to have like a coexisting AL amyloidosis. A lot of patients with multiple myeloma are at an increased risk of infection because their lymphocytes are not working, their bone marrow is infiltrated, there is suppression of normal plasma cell function. There is hypogammaglobulinemia because there's overproduction of one immunoglobulin, so the rest of them are being suppressed. There is also hypoventilation because the patient is having a lot of like rib fractures and pain in the rib cage and spine, so it's hypoventilating, so a lot of respiratory infections. So multiple different causes, but there is an increased predisposition to infections. There are pathological features of multiple myeloma based on monoclonal protein, the subtype of multiple myeloma the patient has, the findings you have on urine analysis, what you see on the peripheral smear, your bone marrow morphology, and your immunophenotype. We're going to talk about all of these one by one. First of all, your monoclonal protein. So a vast majority of patients with multiple myeloma will have M protein, which is basically a protein that is just produced by the plasma cells. We can detect this protein by FLC analysis, by SPEP, by UPEP. We can also quantify this protein by mass spectrometry. Um, Patients who have like an undetectable M protein on SPEP, UPEP, or immunofixation and FLC analysis are considered to have non-secretory multiple myeloma. But basically, M protein is just a protein that is produced by your plasma cells. It's being secreted. We can detect it. So it's pathological. It's a pathological feature of multiple myeloma. There are subtypes of multiple myeloma, like we saw on the first slide. Your plasma cells were making your IgA, IgG, IgM, IgE, and IgD. So again, the subtypes are based on these different types, with the most common one being IgG, which is 52%. And you have IgA, which is 21%. You have kappa or lambda light chain only, which is 16%. You can have a non-secretory or oligosecretory multiple myeloma, which is on the rare end. And then the rest three, IgD, biclonal, IgM, are very rare with 2 and 0.5% respectively. Findings on urine analysis that are pathological for multiple myeloma are dependent on the etiology of kidney damage. You can have myeloma cast nephropathy, which is a large waxy laminated cast in the distal and collecting tubules. These casts are mostly made up of precipitated monoclonal light chains. Here you can see in the bottom two regions, this is myeloma cast nephropathy because they are PAS negative. The PAS positive one is most probably a TAM horsefall protein. Yes. So these PAS negative ones are your myeloma cast nephropathy. There are also findings on peripheral smear that we can see in patients with multiple myeloma, the most common one being Rolu formation, which is basically your RBCs stacked on top of each other like a coin stack. You can have leukopenia, you can have thrombocytopenia, but again, your Rolu formation is like the most common one, being present in up to more than 50% of the patients. So bone marrow is very important in patients with multiple myeloma because there's multiple different things that we can find out from bone marrow. We can do a core biopsy or we can do a bone marrow aspirate. Core biopsy is usually more regularly and routinely performed. Core biopsy is what I saw personally being done in Cleveland Clinic. Um, and it's usually like it gives us a lot of different layers of diagnosis. We can establish clonality through bone marrow biopsy, and we can find out the percentage of clonal plasma cells identified, and this impacts the likelihood of the diagnosis of multiple myeloma. If somebody has like more than 60% of clonal plasma cells in their bone marrow, we can diagnose multiple myeloma regardless of them having other findings of multiple myeloma or not. If somebody has less than 10% to 60% of clonal plasma cells, which is the range that most patients fall in, we usually need other factors or other diagnostic markers or organ impairment present to diagnose somebody with multiple myeloma. We cannot diagnose somebody with multiple myeloma solely based on this range of plasma cell clonality. If somebody has less than 10% of bone marrow involvement, this is a very patchy bone marrow involvement, and this is like approximately in 4% of the patients. For such patients, we need to fulfill the other diagnostic criteria for multiple myeloma, and we need histopathological confirmation of soft tissue or bony plasmacytoma for them to be labeled as a multiple myeloma patient. Since the bone marrow involvement in such patients is more focal than diffuse, like I said, patchy, they may require an aspirate or biopsy from several different sites or an image-guided biopsy of a focal lesion for better results. Plasma cells, we identify plasma cells based on their morphology and on their immunophenotype. So for morphology, the cytoplasm of the myeloma cells is very atypical. These atypical findings are not limited to multiple myeloma, but they are present in multiple myeloma, one of them being multiple pale bluish-white grape-like accumulations, which we call MOT cells or morula cells, which you can see right here, these grape-like accumulations. And then you have like a vermilion staining glycogen-rich A flame cells, which I've put in a picture of here. You might also have Gaucher-like cells, sesorocytes, and crystalline rods. All of these atypical findings can be found in multiple myeloma, but obviously are not limited to it. Immunophenotyping. We can do immunohistochemical staining, immunofluorescence studies, flow cytometry to determine the immunophenotype of bone marrow plasma cells in patients with multiple myeloma. Key features of it being the studies can show the presence of either kappa or lambda light chains, but not the presence of both. You can have absence of surface immunoglobulin. You can have expression of some normal plasma cell markers. You will have absence of CD19 in most instances. Your normal plasma cells express CD19, so multiple myeloma cells do not express CD19, so this is a differentiating factor. Expression of CD45 is usually negative, but CD56 is usually positive. Another takeaway point here is that your 70% of myeloma cells express CD56, which is typically negative in your normal plasma cells. So again, CD19 negative, which is present in normal cells, CD56 positive, which is absent in normal cells. We also risk stratify multiple myeloma into high risk and standard risk. The purpose of doing this is to create a general guideline of treatment because the risk stratification basically gives us prognostic value and gives us like a general idea of how to treat the patient. We do this risk stratification through FISH, which is fluorescence in situ hybridization. Like you see on this chart, there's going to be a high risk and a standard risk. Your high risk is anybody with a 17p30 deletion, a T414 translocation, 1416 translocation, 1420 translocation, gain or amplification of 1Q. LDH more than 2 times of normal institutional upper limit, and these two findings, anybody else with trisomy T1114, T614 falls under your standard risk. We will further discuss this importance in diagnostic and treatment when it comes to that, but just know that we do stratify people with multiple myeloma into high risk and standard risk, and this is the criteria that directs us towards treatment. We come to our last part of this part one, which is imaging. So like I mentioned, people with multiple myeloma have lytic lesions all over their body, and we need to do imaging to rule out these lesions or involvement of the skeleton. So the choice of modality for imaging can be a low dose whole body CT, it can be a PET scan, or it can be an MRI. What we do in each patient depends on how they present and their clinical features. If somebody is presenting with a newly diagnosed multiple myeloma, generally we go for a whole body low-dose CT to create like a baseline assessment of their bone involvement. If we're suspecting somebody to have like a smoldering multiple myeloma, that is, they have no bone lesions on CT and they have no myeloma defining features, we can go for a whole body MRI or MRI of the spine and the pelvis to rule out the presence of any bony lesions. If we are suspecting somebody to have an extramedullary disease, that is involvement outside the skeleton, we can go for a PET scan or a PET CT for diseases outside the spine. We generally keep skeletal surveys for people who are unable to undergo whole body CT, MRI, or PET. So we're doing all of this imaging just to rule out any presence of osteolytic lesions or skeletal involvement, which is a very common finding in multiple myeloma. This is the end of part one. In part two, we're going to discuss how to diagnose multiple myeloma, what are the diagnostic features of multiple myeloma, how do we treat multiple myeloma, what is the general algorithm for it, and different options that are available and certain trials that are going on. Thank you so much for joining. If you guys have any questions, you can let me know in the chat box. You can also send me an email, and you can also message me privately. Thank you.